Hi, I'm Professor Ahmed Mounis, Professor of Internal Medicine at Ain Shams University. I would like to talk about COVID pathogenesis, clinical picture, and diagnosis from medical point of view. First of all, the COVID virus is a droplet infection because have a high molecular weight, have a high 30 kilo diameter. How it transmit? As we know, the transmission is usually done by respiratory droplet infection, where the virus enters the lung, spread from the lung to other organs like intestine, liver, kidney, heart, and CNS. Who is responsible for entering this virus inside the organs is the angiotensin converting enzyme level, which is very high in the intestine, liver, biliary duct, and kidney. Then the virus shed out from the body through the stool, and then the virus goes through the water and food supplement to transmit it again through the fecal-oral route. The animal and only the cat is responsible for this transmission. So take care of the cats. Dog is not the site of transmission, or other animals except the pet is responsible for this transmission. So the virus enters the lung, and from the lung can can affect the body by fecal-oral route. How is it affected? How does COVID invade the GIT epithelium cells? There is a key factor for this entrance. In patients with COVID, a stool sample may persistently test positive, even the respiratory sample is negative for COVID virus. Gastrointestinal endoscopy is performed on patients who were diagnosed as positive SARS in stool sample. A biopsy is taken from the GIT, and histopathological examination and immunofluorescence stain found that the mucosa of this GIT not affected, no significant damage with hemotoxin and leucine. However, virus host receptor, which is a extensive converted enzyme and viral nucleocapsid protein, is stained positive mainly in the cytoplasms of GIT epithelial cell of the stomach, duodenum, and rectum. These results suggested that SARS virus may invade mucosal cell of the stomach and small and large intestine and produce infection. There's two key findings in this group. The first is surprising fact that COVID are present in high acid gastric epithelium. The spike, which is the S protein, we'll speak later what is this S protein, is mediated fusion with the host cell at a neutral pH. So the virus is completely inactive in high acid, which is between 1 to 3 at temperature 39, but moderate in pH condition between 5 to 9, had a little effect on virus titer regard to the temperature. In order, in other words, in order for the virus to invade the epithelial cell without being inactive in the stomach, gastric must be a neutral. The second important finding is the age, which found that the average age of the virus positive population stool sample was 49 years, suggesting that the aging is in the areas of the virus invasion. Age-related increase in gastric pH can be explained by the atrophic gastritis and gastric enzyme metaplasia due to Helicobacter pylori infection. In China and other countries, the likelihood of having atrophic gastritis and enzyme metaplasia increase with age. In the stomach of the patient with enzyme metaplasia or atrophic gastritis, the pH of the surface of the gastric mucosa rising to 3 or more. For elderly atrophic gastritis, the pH found between 5 to 7. Based on the above data, the stomach of elderly people with advanced chronic gastritis is resumed that the SARS is not inactive by stomach acid, but instead of enters the epithelium of stomach, further invades the epithelial cell of small and large intestine. If this hypothesis is correct, the invasion with history of Helicobacter infection may be suspected for oral infection. There is another report recently published 2 days ago saying that the blood group play a significant for the patient to invade. So the patient who have a blood group A have a higher rate of infection more than those with non-group A, and patient with group O significantly lower risk for infection. So the patient, so anyone have a blood group A, he will be have a very good chance to not catching this virus, and those with blood group O will be very susceptible for catching the infection. So when the virus enters the lung by respiratory droplet infection, go the virus to the alveoli, and from the alveoli go to the epithelial cell of the alveoli and start for viral replication. Before the viral replication, I would like to speak about this virus. This virus have an envelope. It's non-segmented, positive sense RNA virus. Have a large genome, as we told before. It's 30 kilodalton. Till 4th of May, more than 3.5 million confirmed to have a virus. 2050 total deaths, and more than 1 million confirmed to cured from this infection. Here's a picture taken for the virus in human culture in the lab by electron microscope. The yellow is the virus. Next, we are speaking about the virus structure to understand how this virus can go inside the body. The virus have main four structure protein, which is S, which is a spike protein, E, which is envelope, M, which is membrane, and N, which is catching the RNA genome. So the N protein hold the RNA genome. E and M protein together create a viral envelope. Here are electron microscope for the S spike. S spike is the most important part for the virus to enter inside the body. This spike protein is attached and fused to the host cell, to the angiotensin converting enzyme receptor, and enters the body. It's found that the S protein has a very high affinity to human angiotensin converting enzyme. And here is the part for the virus to enter, allow the virus enter the body. The S is not the only way to the virus to enter the body. There is another protein, spike protein, another protein called transmembrane protease serine, which is essential for entering. This protease cut open the spike protein of the virus, exposing the fusion peptide. When it is exposed, the fusion peptide, the RNA released into the cell, and the replication start. And here is the transmembrane protease serine 2, which is responsible. And all the drugs right now trying to block this serine protein to prevent virus entering to inside the body. When the virus enters on the body, it releases the RNA genome, positive single strain RNA, and replication will start by viral polymerase, making another copy, which is a negative, then transcription and translocation of the virus, releasing a N protein, M protein, A protein, and spike protein, which travel to the endoplasmic reticulum and Golgi, forming a genome and forming envelope, those intermediate compartment leading to cleave and making a capsid backing, and then the virus is released by endocytosis to infect another cells. The bad news is, and question is very important. Where is the is location? The bad news is these receptors are found in most organs. Found in the alveolar cell type 2, we have two types of alveolar cell, but the virus is found in type 2 alveolar cell in the lung, found in the small intestine, found on artery and vein of endothelial cells, found on the artery of smooth muscle cell of almost organ, and bad news is found also in the cerebral cortex, hypothalamus, and brainstem. The angiotensin converting enzyme to messenger RNA expressed in cortical neuron and ganglia. This is making the symptoms, which is anosmia and dysgenesia, which the patient loss smell and loss of taste because of the virus is found on the neuron and ganglia in the cerebral cortex, so the patient cannot smell and lost his taste after he catching the infection. So why the patients died? Two days ago, there is a study published from Paris found that Pantone Valentine leukocyte secreted Staphylococcus aureus causes necrotizing pneumonia. When influenza is found with the virus, this will making the bavil secreting Staphylococcus aureus, which causing a necrotizing pneumonia. And here is the CT picture for a patient, real patient, died in Paris due to this necrotizing pneumonia. So, do we have a factor associated with worse outcome? Yes. What is this factor? If a patient have a leukopenia, if have high liver enzyme, if have a high LDH, if have high inflammatory markers, if high dimer more than one, elevated prothrombin, elevated troponin, elevated CPK, and acute kidney injury, this patient will not pass smoothly. We have a comorbidities, which is a cardiovascular, diabetes, hypertension, chronic lung disease, cancer, chronic kidney disease, and obesity. This is why the smoker and individuals suffering from chronic obstructive pulmonary disease and high have a higher ACE expression level. This explains why the smoker and the patient with pulmonary lung disease more susceptible to have catching this virus. Innate immunity signals such as interferon also seem to regulate ACE level and thus susceptibility for the infection. The cortex of the GIT and patient with enteric viral infection and other inflammatory condition may have different cytokine profile and thus distinct distinct ACE level in the gut. In addition, genetic polymorphism in of the ACE gene have been associated with diabetes and hypertension. So why the patient with diabetes and hypertension are suspected to make this virus? Finally, I won't stop here, and I promise you that we go on more details for this virus who killing our families and our community, and see you later.